Hello. Today I will present to you cases of UVL fusion. I want to start saying the keynotes of the diagnosis that are choroidal detachment, serious retinal detachment with normal PO, with normal IOP. That is what we see in our patients when they arrive to see us. The causes are inflammatory, can be a trauma, an intraocular surgery, can be uveitis like scleritis and another types of ARADA or pars planitis, or can be idiopathic. Idiopathic is a tricky diagnosis, could be with in hypermetropic eye, non-ophthalmic eye, or without. The first case that I am presenting you is a male of 76 years old. He came with his low vision in his left eye. The eye has no inflammation, but you can see episcleral dilation vessels. And also you can see an asymmetric anterior chamber. It was shallow in the middle, but it was wide in the periphery, so you know that it wasn't a true shallow because it was not symmetric all over. PO was normal, and you could see this in the fundus. You can see in the right the choroidal detachment that is like obvious, and inferiorly the retinal detachment. Complementary exams are useful. Mostly, you can see the retinal detachment, but not always is obvious the choroidal detachment. You have to look for it with ultrasound posterior or high magnification anterior ultrasound with UVM to see here the cilioannular retinal detachment. And if you go posteriorly, you can see the choroidal detachment. Surgical treatment, and it has been mentioned this morning, I agree with the minimum effort to take our patients moving on. So I make an scleral flap, then I make an sclerotomy. I take a flap of sclera, and then that flap was put in his side with a loosened suture. That was the technique. When we make the analysis, it was only collagen. Anything else like is usually found in UVL fusion. The longer the retinal detachment, the worse the vision, so you have to be quick as quick as you can. And you can see the leopard spots that they usually leave after the retinal detachment solution. In a wide field picture, you can see that there is still fluid inferiorly that may take a few weeks to go away. This is the second case, a male of 34 years old. Normal eye, left eye, you can see the drop of vision, 20/200, some cells, and again, normal IOP and a mild vitritis. You can see these lesions nasally and a shallow retinal detachment. When we lift the upper lid, we can see this patchy salmon lesion. We took it, we analyzed it, and the analysis wasn't conclusive, so we keep on studying the patient, but we follow up the patient. The patient didn't come back. After a few months, he came back like this. You can see the high protein of this retinal serous detachment, 4 times the serous level. Apparent absence of vitreous gel. By this time, no light perception. Visible anterior hyaloid, and inferior and right, you can see all the changes in the vasculature of the normal retina. The cap lipper, it's alterated. So we don't think in these cases to go from in. Like it has been said by Javi yesterday, when it's a serious retinal detachment, you want to drain, like they drained beautifully yesterday, the Coates cases. We take a biopsy, a partial thickness choroidal biopsy, and after 5 days of the biopsy, this was the result. Just with the scleral flap, the external biopsy, and then a loosened suture in the flap. No light perception, still was his vision. As the diagnosis was for benign lymphoproliferative hyperplasia, we treated this patient with corticosteroids, and visual improvement was to light perception. The minimum we make to take these cases of serous retinal detachment for us is the best. So we propose it's still going on this technique of a partial scleral sclerotomy to treat this serious retinal detachment. Thank you very much.